Thank you guys so much. Yeah, I'm so happy to be here. I feel like I get prayer a lot. Actually, I was walking in this morning and someone said, hey, I saw you at a session yesterday and the Holy Spirit told me to pray for you. And she stopped and prayed with me. So I'm excited that I just get lots of prayer. I know where to come when I need some extra encouragement. And as I was preparing for this talk, I was wondering how to start it off. And initially, I thought my intro would probably go something like this. I was going to say, I always wanted to be in a room like this. And by room like this, what I meant was not the temperature, because all conferences are freezing, right? So I hope you have your jackets with you. And not the lighting, because fluorescent lights don't always, help my complexion so much. But a room where there are people like me. And by those people, I mean the people who are kind of blessed people just like you and I. And when I was thinking about that, I just wondered how amazing it would be to be in a room where people are really focused on their vision, or they're focused on how God is using them to elevate the kingdom, where they're using their positions to be able to move forward. And I was so happy to be here because this is the feeling I thought I would get. I found my people who are just like me. And I thought that was going to be the intro, and it sounded so great until I was actually practicing on the plane yesterday. And I just heard overhead as I was kind of rehearsing through the slides, if there's a medical professional on board, please get the flight attendant. And right before my eyes, I was like, oh my gosh, should I raise my hand? Is it going to be me? But a guy behind me was like, oh, I come and help. And I was like, yeah, me too. I'm ready. But the person ended up being fine. They had a seizure on the plane, but they were okay. And what it made me think about is sometimes, actually, I feel like I'm at the wrong place at the wrong time. And those moments stem from, one, this is probably like the 5th time I've been on a plane with a medical emergency, so it happens a lot. So I used to ask God, like, why? I'm always at the wrong place at the wrong time. And I still remember in residency, I was walking out of the hospital. Actually, I had to go to a rotation at a clinic. And I'm like, yes, finally, my shift is over. I get to go do some outpatient. It's going to be great. And someone asked me, they're like, are you a doctor? And I'm very hesitant when people ask me this because I did have my white coat. My stethoscope was still on. So it was pretty obvious. They're like, yeah. This guy is passed out in the men's bathroom. And I'd never really been in the men's bathroom before up until that point. And I go in there, and unfortunately, you see drug paraphernalia everywhere. He had overdosed. He was on the toilet with like agonal breathing. And that's why I'm hesitant now when they ask for doctors. So please pray for me in that area. So thank you so much for coming to my talk today. It's entitled For Such a Time as This, Transforming Our Lived Experiences into Relatable and Compassionate Patient Care. And today, I really just wanted to get a sense of who's in the room. So if there are medical providers, can you raise your hands? Okay, good. Any administrators here? Awesome. Any non-physician or medical, other types of providers, so like dentists or social workers, behavioral health. Okay, so we got lots of different people in here, which is great. So I'm excited. I always like to kind of get a sense of who's here before we kind of start talking about it. So thank you guys for letting me know. So here are some expectations. We're going to talk. It's going to be a conversation. I grew up in Black church. You talk back to the speaker, okay? If everyone agrees, say amen. All right, it works. You guys can do it. Awesome. We're going to laugh. My jokes are not the best. So, just bear with me, laugh anyway. And we may cry for the jokes, but it's okay. We're going to really be talking about some challenging topics. So that's where the tears will come in. I do like to say I give it what I would call a trigger warning, because as we share some of patient stories and some things that we're going to be talking about today, you guys may have certain emotions that come up. So I just want to let you know that expectation. Some behavioral health people said they're in the room, so we may need them. And then most of all, we're going to transform. We're hoping to just make this a conversational experience where we're learning from each other, where we're growing. But most of all, we want to walk out of here with a different perspective, a different view of how we really care for each other and care for patients. All right, great. So a lot of people have heard of adverse childhood experiences and trauma-informed care. And what do those words mean to you guys? Again, we're going to be talking, right? So any thoughts that come to mind when you think about adverse childhood experiences or trauma-informed care?
Understanding their overall health, or understanding their trauma in the context of their overall health.
Yep, for the patient. Yep, exactly. Any other thoughts? Are you guys familiar with adverse childhood experiences? Okay, most people in this room now, I remember like years ago, it was like this new topic that everybody was talking about, and so was trauma-informed care. I think we're more well-informed about those aspects of our care, and I feel like especially us trying to do kingdom work, we're even more intentional about practicing medicine in that way. But originally, the study was done by Kaiser Permanente from 1995 to 1997. It was over 17,000 people who were part of the study. And what they were trying to figure out was, based on certain life experiences in childhood, what are the health outcomes? So that's where the adverse childhood experiences came in. Sorry, I've been having some trouble. Technology always fails me, so pray for me in that area too. All right, so we'll talk a little bit about the ACE study. So what happened, there's a paper, it's called Relationship of Childhood Abuse and Household Dysfunction to Many of the Leading Causes of Deaths in Adults. Okay, so what they did is they looked at 7 various experiences that adults had in their childhood and whether or not it made any difference in outcomes. So one was psychological abuse, physical abuse, sexual abuse. They also looked at violence specifically against someone's mother. And then if there was anyone in the household who had substance abuse, mental illness, or imprisonment, and what would those factors, how would those impact people's experiences and their health outcomes? So this was done by Dr. Felitti and his team. And when they were looking at this, they found that if people had 4 or more categories of childhood experiences, they tended to have higher rates of things like suicidality as adults. They suffered with obesity. They had heart disease. So a lot of factors that we look at when we're adults, they were seeing this all stemmed from some of these similar childhood experiences. And then the conclusion of the study, so this is kind of word for word verbatim from what the study says. We found a strong graded relationship between the breadth of exposure to abuse or household dysfunction during childhood and multiple risk factors for several of the leading causes of death in adults. So it sounds like you guys are pretty familiar with that, right? So I also started thinking about trauma. And I always look up definitions for words, but the Oxford Dictionary, they define trauma as a deeply distressing disturbance or experience. And then if you look at DSM-5, but specifically related to PTSD, this is kind of the beginning of what it talks about. So it says exposure to actual or threatened death, serious injury, or sexual violence. And that could be directly, so if you yourself have experienced some traumatic event, okay, we can call that trauma. It could be witnessing, meaning you've seen someone else experience that traumatic thing, or lived in a sense that you've heard that someone close to you also experienced something challenging or difficult. So just by these definitions, all of us in some way have experienced some type of trauma, or we have someone close to us who've experienced it. So these are the definitions when I'm talking about trauma-informed care as we move forward. This is what I want you guys to keep in mind, okay? And then I actually got this from the Franklin County website, which is in Pennsylvania. So if anybody's from Pennsylvania, maybe you know about Franklin County. I don't particularly, but they actually took this diagram from SAMHSA. So that's the Substance Abuse and Mental Health Administration. And it was talking about how to use trauma-informed care specifically when you're working with patients. So these are the 4 R's of trauma-informed care. And I was just wondering out of curiosity, are you guys implementing or using trauma-informed care in your clinics and clinical settings? And what does that look like in a practical way for you? Okay, awesome.
So they did a whole hour-long webinar on trauma-informed self-care
Mm,
for, so that you can avoid burnout and understanding vicarious trauma and compassion fatigue. So we implemented that. They gave us handouts for 6 different areas of creating a good self-care plan.
awesome.
And it talked a lot about preventing yourself from being, re-traumatized or being triggered by patients that you're helping. And so that was helpful. The second piece for our clinic is that we are doing crisis prevention verbal de-escalation training.
Okay,
And that's going to go out to all staff, but that's about how to handle patients that are in distress.
yeah,
And also like how to verbally like de-escalate the situation. So those are like 2 ways, because it's almost like you have to do yourself, others, and then as an organization, what does it look like to be a trauma-informed organization?
exactly. No, that's great. I think often what happens, because a lot of us here, clearly we're very compassionate, we care about our patients. It's really focused on what we can do for the patient. And I feel like not a lot exists actually for the providers or the people who are actually doing the caring for. So it's great that you guys are doing that. You can probably give the rest of my talk because I'm going to talk about that.
Because this is really going to add to that, and this is really helpful.
Yeah, great. Anybody else, practical ways? I think you summed it up really well. Any other thoughts? Go ahead.
So for us, we trauma-informed care is really like just the basis of everything we try to do. So we're integrated care.
Awesome.
And part of the ways that we've been really investing in that is just having the right people in the room. So we've started an integrated behavioral health program where clinicians will come into medical visits if we notice like there are some distressing symptoms going on, like some sort of like trauma, PTSD, depression, anxiety, and so we'll have a mental health professional come in and talk to them with their skills, with their trauma-informed training.
Great.
And so it kind of like, it helps us be trauma-informed with each other as a team too and realize, hey, this is when I need help, or hey, like, I got this, like I can do this, and just like staff everything together.
Yeah, no, it's great to have like those types of conversations because I feel like naturally people may not have an environment that they feel comfortable enough to discuss those things. So it's great that you guys are implementing that. Awesome. So these are the 4 areas, right? So one is realize. When we're thinking about trauma-informed care, we want to realize the impact of trauma and understand what trauma means for the patient specifically. So that's important for us to do. The next step is recognizing. So we want to know not only realizing just, overall as an overarching theme that trauma exists, that patients have experienced it, and that us as clinicians also have experienced it. But now, what are the actual signs of trauma? What does it look like? I feel in this day and age, there's a lot of talk about burnout. We all want to go to those sessions. Sometimes I wish if I had, the magic cure for burnout, I probably wouldn't be doing what I do. But it's great. It's great that we're having those conversations because those are much needed. But recognizing what are the symptoms for our staff, for our patients, for our providers, because that's also going to be important. And then responding, okay? So that's integrating knowledge about the trauma that you're experiencing, but also you mentioned like having policies and things put in place on an organizational level to make sure that we're truly moving forward with true trauma-informed care. And then resist. So we talk about the re-traumatization part as well of children and adults and other people on our care team. So those are important factors, especially when we go back out into clinic on knowing how do we do that, how do we integrate all of these aspects in our day-to-day in a practical way. And that's why I asked for a practical example, because sometimes you go to big conferences and people give all these stats and all of this information, but it's not practical. It's not something you can actually take with you or learn. So I'm hoping today we can talk more about some practical things to do. So what came to me was this idea of trauma-informed care and adverse childhood experiences was very common in how I practice. I'm very patient-focused. I understand I'm naturally a compassionate person. So it made sense when it came to the patient. But I was like, I went through one of these childhood experience surveys, and what shocked me is like, oh my gosh, my score is really high. And I'm thinking about trauma as it relates to not only my own lived experiences, but people that I know closely, family members, friends, colleagues. So I was like, if I take all of that into consideration, not just my own specific traumas, but things that I've seen other people go through, then this score is so high. So I've been trained on how to be compassionate for the patient. I've been trained on, how to use trauma-informed care. But how do I, as a physician who've actually experienced this now, translate that into a way of not only helping myself, but also helping my patients at the same time? So that's what I wanted to talk about. So I tried to look up, some literature and trying to figure out more about it. And there's not a whole lot out there when it comes specifically to the physician who've experiences ACEs themselves. What I was gonna do is, again, technology may fail me, but on your app for the conference, I put a little poll there. I'm gonna see if this will. Can you guys read this, or is it too small? It's a little small? Okay. I had a hyperlink in here, but I think just, again, because I was having trouble with this whole, someone helped me earlier. I don't know if they're still here. Yeah, I'm using like 2 screens, so apparently but I can read them out to you. So what I want you to do is, and we don't have to share our answers. I actually created a poll on the app where you can let me know how many points maybe in the room, what's the average amount of points that people are experiencing. So the first one is, and this is not just related to you, it could be the definitions we talked about. So either like a friend, family member, colleague that you know who may have experienced this, you would answer that answer as a yes, or give yourself 1 point, right? Did you feel that you didn't have enough?
Is this for us now?
For now.
This is for childhood, right?
It's from childhood, yes. So it's from childhood. Well, I guess I get what you're asking. You're asking if you want to answer as if when you were a child or for right now, right? Is that what you're saying? Okay. So it's meant for childhood specifically, but I would say it's okay if you do it based on now, because it gives us a sense of kind of where you are now. Does that make sense? Yeah. So, okay. So number 1, did you feel that you didn't have enough to eat, had to wear dirty clothes, or had no one to protect or care for you or take care of you? Number 2, did you lose a parent through divorce, abandonment, death, or other reason? Number 3, did you live with anyone who was depressed, mentally ill, or attempted suicide? Number 4, did you live with anyone who had a problem with drinking or using drugs, including prescription drugs? Number 5, did your parents or adults in your home ever hit, punch, beat, or threaten to harm each other? 6, did you live with anyone who went to jail or prison? 7, did a parent or adult in your home ever swear at you, insult you, or put you down? 8, did a parent or adult in your home ever hit, beat, kick, or physically hurt you in any way? 9, did you feel that anyone in your family loved you or thought you were special? 10, did you experience unwanted sexual contact? 9 was, did you feel that no one in your family loved you or thought you were special? So kind of calculate that in your head about what the number is. If you go to our conference app, underneath this session, you should see a poll. You'll be able to put your answers in there. So basically, do you guys see it? Yeah. Okay.
The option for 1 through 4.
That's the only option?
Well, no, there's 3 options, but 1 through 4
You can't click on it? Technology. Oh, I was hoping it wouldn't fail me. Okay, let me try one thing really quickly. Oh, I see. Okay. I'm going to do a new poll underneath. Okay, it should say poll now. So use that one instead. Is that better? Okay. Yeah, I thought it was cool. I didn't even know they had that feature. And now you guys know. You could tell, if you're presenting, you can use it now. Sorry. Okay. Okay. You guys still need a minute? Are you okay? Good? Okay. Awesome. So I'll tell you the results. So 20 people were in 1 to 4. We had 4 people in the 5 to 7, and only 1 person was 8 out of 9. So that kind of gives you a perspective of, with the people in the room, the average person really has, I guess, a lower amount of trauma who's practicing or doing healthcare. And there's a small subset of people who are practicing who have significant trauma. So that scores 8 to 9. And I kind of found that I fell more in the middle of those. So I started to ask myself, how do doctors, as I mentioned before, how do their personal experiences with ACEs or life-changing situations relate and interact? How does it affect how they relate and interact with their patients? So I was wondering that a lot, because if I'm having higher scores of kind of traumatic-related experiences, then is that affecting how I'm providing care to my patients? And if so, what can I do to change that, to make sure I'm actually impacting patients in a positive way, right? So I started to do some research to look for studies that actually existed about this. And as I mentioned before, it's not a lot of them. So one study, it's called Adverse Childhood Experiences in Community Physicians. And what they did, there was a small subset of physicians, and they actually said 81% had never even heard of an ACEs questionnaire before. And then only, I think, 3% were actually using it regularly in their clinical practice. And 55.5% reported no history of ACEs, which is higher than our group today, actually. Most of us, at least maybe even all of us, have had some type of traumatic experience, whether it only was a score of 1. So I thought that was very interesting. And it had me start to think about these questions. So one was, initially I was thinking, why do bad things happen to good people? And then as I was talking to God about this, I scratched that question out. Because I've been trying to get on the Pearly Gates hotline for a long time, and no one seems to want to answer the phone. So instead, I started to ask these questions. What is God trying to teach me through the challenges? How is he shaping or molding me to be a better version of myself? And then how could these lessons be translated to becoming a better physician who provides more relatable and compassionate care? And a lot of us have probably asked the first question that I scratched out. And over years of praying and asking God for things, I really realized some things you shouldn't ask God for unless you're really ready for the answer. Right? So I asked for patience, and the things that came with asking for patience, I was kind of like, Lord, can you just tell me what I need to do? You don't have to show me every time. And then I've even asked, like, okay, God, I don't want to be on the, strong warrior list. Can I just take a break for a season? I don't have to go through all of these things. And I feel like another way that we learn, besides from our own personal experiences or learning through patients. So I'm going to share some information about a patient case, and then I'll have some questions to follow where I would hope you guys can get into smaller groups and just have some discussion. And what I want you to do is really think about if we're thinking about the ACEs study and trauma-informed care, how would we manage our talk with that patient? How would we empathize with her? So I just wanted to present this. So this is a patient case. So we had a patient. She was telling me about her experience in her pregnancy. And she said it was horrible. She had morning sickness throughout her pregnancy, hyperemesis. And she remembers that on one day, her water broke, and she was only 26 weeks. So of course she was afraid. As far as her medical history, she was very healthy. She had a slightly high-stressed job and felt like she had a lot of different responsibilities overall. But overall had been taking her prenatal vitamins, going to checkups regularly, and had no previous history of like preterm labor or having premature infants, nothing like that. So she was quite shocked when this happened to her. And then she said she ended up going to the hospital, and there she felt like she really didn't get the care that she was hoping to get. So she said she stood in the lobby, no one came for a while. She was leaking because her water broke, right? So she was hoping someone would like be there to talk with her, that she would see a physician, and no physician came until the next day. So she was just feeling very overwhelmed with what was going on. Her husband also worked out of state, so it was just a lot of things happening for her at the time. And then while she was there, she ended up being in the hospital for about 3.5 weeks or so, because they were hoping that in time, the baby would grow big enough for delivery. They were able to stop her labor, things were going okay. And then what ended up happening, she went into labor again, and at this point, she had been going from labor and delivery to antepartum multiple times. So usually antepartum is when you are not in labor. So for those who maybe not as familiar with maternal health, you're not in labor, but you have another medical issue that is causing you to be hospitalized. So they'll have you on a separate section of the hospital. But when you're in active labor, you'll be in a different part. So she had gone from antepartum to labor and delivery, antepartum, labor and delivery like 4 or 5 times. And this was another time she was like, no, she was saying, I have contractions. I can tell I'm having contractions. Like, can you call the doctor? They're like, no, we're going to put you on antepartum. But she was like, I'm in so much pain. I'm having contractions. And they're like, no, we're going to move you antepartum. We don't have any medication on the list. No orders are in for that. So she kept having these like very challenging experiences, even though she felt like she was in labor at that time. So what ended up happening was someone finally checked her cervix while she was on antepartum. She ended up being 6 centimeters. They moved her back again to labor and delivery when she was there. And while she was on labor and delivery, a nurse came in maybe a couple hours later to check her cervix again, and she felt the baby's umbilical cord. So she had a cord prolapse. She had to be rushed very quickly to have an emergency C-section. And just prior to that, before knowing she needed an emergency C-section, she was like, I'll just get an epidural, because she hadn't planned that to happen, right? She was gonna have a vaginal delivery. And during the time of getting the epidural didn't really work. She was still in pain, and she ended up dropping her vitals to like 60 systolic. So everything that could go bad went bad during her experience. So finally the baby was delivered. The baby was brought to NICU, which makes sense because he was premature. And then hours later, they come and tell her, sorry, we're having to use epi, which usually means they are trying to resuscitate her baby now. And her baby ended up passing. So she had such a unique and challenging and difficult experience. She was a Black woman, and we know a lot about maternal factors, even with Black women who follow really the textbook, right, of doing the right types of prenatal care, they still have worse outcomes. So this is the patient in front of you who shared the story of what she's been through, who's meeting with you, probably just for her annual visit. How do you talk to her? So I would like you guys to get into groups and talk about how you, now as a very informed provider and clinician, thinking about trauma-informed care, thinking about adverse child experiences, what would you say to her? So if you guys can maybe just get into little groups, and then we'll have an open discussion afterwards. So these are some of the questions. How would you interact with this patient? What questions would you ask her? How would you empathize when you've maybe never felt this way? If you're a man, I don't think you've been pregnant before, so maybe, you've just had a different experience than she's had. All right. Okay, for the sake of time, can you guys hear me? Yeah, good, okay. For the sake of time, I was just gonna ask if you guys felt comfortable sharing maybe some of your thoughts or to the question, some of the discussion that you guys are having amongst yourselves. So the first question was, how would you interact with this patient? So I intentionally gave you a very difficult scenario because this is what really happens in clinic. And again, we're talking about what are practical ways to be able to take what we're learning and implement it with our patients. So I wanted to give you a very difficult case because I think it sparks a lot of discussion, but I would love to hear what you guys thought about that. How would you interact with this patient? What are your thoughts? Yeah, that's so important. And I think too, and we'll talk a little bit more about this as we go along, sometimes we feel like we need to have the answer. And oftentimes we need to be present, and that's enough. And I feel like especially, as a physician, people come to me for answers. So I think I'm trying to solve something most times, right? And often they have a problem, and that's why they're coming. But I've learned over time that just being present, I call them my social visits. I have patients who I feel like I'm not really addressing any medical concern. It's mostly lots of prayer that's happening in the room. But those are the times I feel like patients, we connect the most because I'm actually just listening and acknowledging what they're going through. I don't have the answer to fix it. They may be homeless, living in their car. I had a patient like that a few weeks ago. I don't necessarily have a solution in this moment that could help his homelessness per se. But he keeps coming back because he knows that I'm listening to him and being patient with him and praying for him as he's waiting on his own answer. So I think that's something important for us to really think about and consider, that we don't need to have all the answers. We just have to recognize that the patient has something going on. That is so powerful. A lot of times things that happen the most transformational things in my clinical experiences are not me giving a diagnosis or prescribing a medication. It's actually listening. And sometimes the patient, we cry together, we laugh together, I hear their story, we pray, and they come back and they're so grateful that I just listened to what they had to say. So I think that's so important. Any other thoughts about maybe how you would interact with her or things that came to mind? I heard a lot of discussion, so I know it's a lot of good stuff out there. Anybody else want to share? And it can be any of the questions. So the other thing was, what questions would you ask her, and how could you empathize with her? And specifically when you've never had a similar experience, and I think that can make it hard. I'm a Black woman. I grew up in poverty, and I work with impoverished communities. In a lot of ways, it's relatable, but I still have my own lived experience that is still different from my patients, right? But in some ways, it's similar. So it makes it sometimes easier to relate because I remember what it was like not to have hot water or electricity, like some of those things that they may be going through. It's relatable. But for a lot of my colleagues, they never had that lived experience. So how do you know? You're right. If you think about it as a friend or a family member, someone's close to you, it definitely does change the way you interact with that person, even if, again, you haven't gone through that experience. Great. Any other thoughts? We'll still be talking. We have lots more conversation to come. So the person that I showed you is actually me. Yeah. So the patient who had that difficult experience and that loss, it was me. So that changes how you see healthcare. When you're hospitalized now, you're the patient. When you have a loss, when you have a trauma, it makes you look at things much more differently. So I thought I was compassionate. I thought I was caring. I stayed late praying with patients all the time. I went out of my way. I paid for medications. I do all the things. But me living my own story is actually what helped me to be more compassionate. and more understanding. And I've talked a little bit about, my upbringing. So I'm a Black woman. I'm from the deep South. That says a lot without saying anything, right? And growing up, I mentioned I grew up in poverty, but my family was a working poor. So we never got any financial assistance, but we just made barely enough to get by. So that's even a little more challenging in some ways because you don't really make enough for assistance. So I went without some physical things at times, but my family was so loving. It was huge. Like my mom's side of the family, there were 12 siblings. My dad's was 10. There was great food. I'm from Louisiana, so Creole food was amazing. Nice gumbo, jambalaya. There was always something good to eat. So I learned so much. It was such a rich environment, even though we lacked a lot of things. And that actually helps me the most as a physician, because growing up, I learned the importance of community. I learned the importance of kindness. I learned the importance of helping others to be their best selves, even when they don't have things financially. So that's what drives me to really care for my patients, to provide, to go out of my way, to extend my time and energy. And it gives me a lot of passion for what I do because of my own lived experience. So sometimes what we have to do is just remember that our experiences are different from other people's, but they're valuable. Our stories are so valuable, and we can take them with us, wherever we go. So back to the questions I was asking. So what is God trying to teach me through the challenges? Because that was a lot. I'd actually just finished residency, and that was my first job. 3 months into my job, my water broke. I ended up in the hospital for almost a month. And imagine, I just started working there. I'm like, oh my gosh, I'm taking medical leave already. And then I had a bad outcome. So it was hard trying to get back into clinic. As a primary care physician, I'm family medicine. I was doing prenatal care. I was seeing children. I was seeing adults. And I had to pause, actually, on prenatal care for a while because it was hard. I had to pause on seeing newborns because it was hard. So sometimes your lived experiences, it makes you start to think about things in a different way. It makes you start to ask, not the question, why do bad things happen to good people, but God, what are you showing me through this? Because some things we can't change, right? In life, the younger people say life is lifing, and it is. Things happen to us, life happens. So we want to use those experiences, and even for your own stories, for what has happened in your life. What is God trying to teach you? So any thoughts, and just in general, of like, what do you think God has been trying to teach you through some of your own personal challenges? Any thoughts or words of wisdom through the years, through the challenge, through the suffering? There's some really good talks about all of these topics that I've gone to here. Yeah. So that would take a whole hour to unpack all the good nuggets in the story of Esther, and you did a fantastic job. Thank you with explaining it. But some of the things I wanted to highlight about Esther is, one, she had a story, like all of us. She lost both of her parents, as you mentioned. She was being raised by a family member. She's being summoned to leave her home and go into this country. So that's the thing to keep in mind. It's like we all have stories, we all have challenges, and the Bible is full of people. And if, it's not short on the amount of people who had some challenge and how they overcame it. But the title of my talk was, For Such a Time as This, is just to remind us. And that's what in Esther 4:14, that's what it was saying, is that sometimes all of the things that have happened, all the things that make up your story is for this time. It's for God to use you in an impactful way to help other people, to help people move forward. So although my story is challenging, difficult, I try not to think about it a lot at times, it helps me to move forward into what God is calling me to do. It helps me to be more compassionate with my patients. It helps me to share other people with other people so that they can go out and be proud of their stories, even the bad parts, because that is what we need to be more compassionate, to be more relatable. So I thought Esther's story really summed that up really well. The other question, so that was the first question. The second question is, how is he shaping or molding me to be a better version of myself? And what I think happens a lot of times is kind of two options, really. One is the trauma, the challenge, the difficulty can make us revert and be very quiet with sharing our story, or it can empower us to share in a way that helps cause transformation. And I've chose the second option, right? And that is because all of those times that, even in the Bible, you think about, people in Moses' time, that Moses never even made it into the promised land, that there were 40 years of them with this promise that God was waiting. Why 40 years? And I think, with my current age, I'm like, 40 years is not that bad, really. It's not that long of a time period. But it's sometimes because God uses what we went through to do something inside of us first. And you have to be the one to want to make the change, to want to have the transformation, to understand what are the lessons, right? So for me, after that happened, I ended up actually going part-time clinically. And I do another part-time of more admin. But I felt like that's what I needed in that season. And it was helpful for me. But I felt like, I was the patient at the hospital. I was still seeing patients. I was doing virtual visits. I was so compassionate. I'm sitting in the hospital and I'm doing my computer's on my lap. I'm doing virtual visits with the patient while I was there. God had to shut some things down, right? Stop, stop. But those challenges and experiences help us so that we can actually grow and learn. And the other thing, I've always been caring. I've always poured out a lot. And I wasn't replenishing. And I feel like that's very common, right? We talk about compassion fatigue. That happens all the time. You're not replenishing. And that's what we need to start being aware of. We need to worry and learn more about self-care and soul care, right? And then these are two passages. Jesus took breaks. We forget that sometimes, right? He went off. He would leave, the disciples and go and pray on his own. We need breaks. We need time to ourselves, even from our own family sometimes, to recenter and to pour back into ourselves, because we don't do that very often. And I find in this setting, a lot of people are not as good at that. Jesus set boundaries, right? He was like, if someone in, this town, if they're not listening to you, shake the dust off your feet. We don't set good boundaries. We commit, we overcommit, we keep doing because we think that's the Christian thing to do. But if we're really modeling the things that Jesus did, we want to model all of his behaviors, and those things are necessary. And then the other question, for the sake of time, how could these lessons be translated to be better physicians who provides more relatable and compassionate care? And I know that's why you guys are here today. One is thinking about our own biases, and you mentioned this before. And that's important, right? There's a lot of implicit bias. We don't really even recognize how our own experiences have made us think about or look at things in a certain way. But it's good to recognize those things. And that helps us, really, as we move forward, to think about how we're interacting with people, how people see us, how our patients see us. But the biggest and most important thing in doing this is recognizing that Jesus is the perfect example. And a lot of people had trouble talking about, well, if I don't have that lived experience, how do I do it? Jesus didn't have he was not a sinner, and he hung out with sinners. He did not have that lived experience in any capacity, but he was the best at doing that. And these are the three ways. One was humility. And humility is not thinking that you're less than someone else. It's recognizing who you are, recognizing your story, but noting that someone else, their story is also important, right? He was very humble. You think about so many examples in the Bible, but the time he said, let those who have not sinned cast the first stone. He could have done that, but he didn't. He was humble. He recognized his importance and other people's. Empathy. And empathy is the ability really to understand and relate and try and relate to other people who may not even have the same lived experiences. Jesus was great at doing that. He wept when Lazarus died, right? He was with Martha, and she was weeping, and he was weeping too. And that's part of our story as well, is just recognizing we can just be present. We don't need the story. And the last is surrender. And that's saying, God, I don't have all the answers to help this person, but you do. I don't have to always fix it, but you can. So learning to do that, I think, is what really helps us to be able to be the most caring and compassionate when we're providing care for our patients. And I'm going to leave you with this. This is something that I try to remember, because we can shy away from our own stories. We can shy away from, the challenges and the good things that we do, right? In the same way, let your light shine before others, that they may see your good deeds and glorify your Father in heaven. So us talking and having conversation is to give God glory. That's the story that's the most important, right? So think about, how are you going to use your story? How are you going to impact others? How are you going to be more empathetic? How are you going to listen to your patients in a different way? And I just want us to end with this declaration and tell you a little bit about how I use my story. So I'm a physician, so I work in clinic in the underserved. It's a lot of challenges. I'm in Memphis, Tennessee. But I also had a difficult experience as a Black woman going through medical school, who was the first generation doctor. That was a different lived experience. So I also provide a lot of mentoring through CCHF for students. And I also, right now, actually at Christ Community, we're starting a residency program, a family medicine residency program. So that's another way that I'm able to be able to use my story and lived experiences to help someone else have a better experience than I did, right? And I'm also a certified life and executive coach, which is very different from everything else that I do, but it's a way to uplift others, to help other people in a different non-clinical way, recognizing the importance of resilience. And I think resilience, sometimes God, I feel like, gives us a story, a word that each of us have, and your life is reflective of that word. And sometimes I don't want resilience, because what comes with that is you being resilient from something, right? But I just wanted to end with this. For the sake of time, I'll let you guys go. But just, I like to, especially like when I'm working with some of my clients in life coaching, is to declare and say a thing over yourself in your life. And that's important. That's why knowing the word and scriptures is important. You're declaring and saying a thing over your life, and you start to believe it and you walk in it. So I wanted us to end with saying this together, because as we're leaving and we're implementing these practical tools and ways to really get closer to our patients, we also need to find ways to get closer to God so he can help us to be who he really designed us to be, right? So let's read it together. Today, I am deciding to show up as my most authentic self. I will not allow my previous setbacks, negative thoughts, or perceived limitations get in my way. I will become the most healed and whole version of myself and the person God is calling me to be, because my family and community needs that version of me. All right, great. Thank you guys so much.